I've been a CT tech for 12 years before I got asked to open the 3D lab. So CT was kind of like my thing in life to do. And I love getting back to the scanner for these patients. These patients are special to me, and I like to treat them that way. Doing that is actually probably the key to getting a good study. They are like fine china. You gotta treat them with kitten gloves. You gotta walk them through, keep them calm, inform them of every step of the way, because like Dee Dee says, the heart moves. When they get anxious, the heart moves faster. This is the CT scanner. When you walk in, it's intimidating. The patients who've never seen anything like that, they're going through there and they're like, I have to be into that circle. Keep them calm. So we have on our scanners 2 modes of gating, retrospective and prospective. Difference between the 2, retrospective, you get the whole heartbeat. The beam is on the whole entire time. With prospective, it's only on a certain time. So therefore, for all of our TAVR cases, we are using the retrospective studies gating, so we can get all that movement of the heart through the whole thing. When we scan these patients, ideally, we like the heart rate to be as low as possible. Gating does turn off at 35, and it will turn off again at 125 of the heart rate. So again, keeping these patients calm is really important. We don't use nitro. We don't need to. We're not looking at the coronaries. IV placement and sizing. We like to get the largest IV possible, 18 gauge. We put it in the right anticube so it doesn't form artifacts going over from the left subclavian over to the arch. We use a mix on our injector now. We've been able to decrease our dose of contrast using that. We will scan patients with a lower GFR, but when it goes below 45, we actually have a hydration protocol that cardiologist controls. So they go to the hydration floor, and what they get is determined by cardiology. So when the patient's brought into the room, they are hooked up to the EKG, and we've trained our techs to look at the EKG, to look at normal rhythm, AFib, PVCs, to try to determine how we're going to get the best scan possible. When we have problems with the heart rate, that's where we run into problems with the scanning. And fortunately, on our scanners, we are able to edit the EKG strip so we can get better images. And it works most of the time. So once we bring the patient in the room, education. Education is the most important part of scanning a patient. Let them know exactly what's happening, exactly what you expect from them. You know, these patients know why they're here. They know how important that this study is to them, and I've never had a patient not cooperate. They do their absolute best, and they're really the rock stars of this study, because without their cooperation, we couldn't do what we do. Always know the history of your patient. Make sure that we are doing the right study. So our techs are comped. They're trained for this particular exam. I go in with them, walk them through, and let them perform as many as possible until they're comfortable. We comp our techs at least 10 patients into them, or they can do them unassisted. And once they are comped, they are able to go ahead, and I don't have to be at the scanner anymore. We recomp them every 6 months just to make sure that no pieces are being missed, because everything kind of gets slid under when you're trying to be really quick. Each tech does about 2 cases a week just to keep their knowledge up on the studies. And we try to schedule 2 comped TAVR techs at a time so they can work with each other. So the other thing that you need to know before you start the exam is patient's height and weight. That is used a lot in our studies. It determines the amount of contrast being used. It determines the technique being used. The heart rate, it determines the cardiac type that we're going to use. We test our patients in different breathing techniques. Different breathing techniques will change the heart rate of the patient. Most of our patients are shallow breath in and hold it. That works most of the time. When we have our patients that are in AFib or having PVCs, the bear down technique usually is our technique of choice. It somehow puts the heart back into a rhythm for a short period of time, but enough time for us to be able to scan the heart. We also have the patient's head turned to the left. Why do we do this? This is the way the patient is actually placed on the table in the cath lab. So when we use our cardiac access approach, our carotid access approach, patient is already positioned the same way as they would be on the table in the lab. So therefore, the anatomy isn't changing from one department to the other. So we scan quite a long distance. We scan from the mid-neck, including the thyroid, all the way down to the pubis. But we don't gate that. If we gated that, that's a lot of radiation being used. So we only gate to the bottom of the heart. Once we get there, the scanner switches from cardiac mode to helical mode, and our scanner only takes 6 seconds to do that, so we're able to do it in one bolus at a time, one complete bolus all the way through, where we don't get an interruption from the chest to the abdomen in Hounsfield units. So then we scan from the diaphragm all the way through the pubis. Why do we start at the bottom of the heart and not go completely through the heart? When we are planning for our iliac access or our transcaval access, we actually need the renal veins and renal arteries in order to map that out. When we are scanning that whole area, we have to make sure that everything is actually the same, from the chest to the belly. All of our offsets are the same. Our start location and end location are exactly the same. That way, in our software, we're able to load it together where it would be one complete image and not broken up in just the chest or the belly. It gives it more true anatomy. This is the scan type and the heart rate override. So our scanners will adjust for different heart rates. So we have segment, burst, and burst plus. Segment is used under 75. Most of our patients, that's what they are. But the pitch will change for burst and burst plus, making the table move faster for a faster heart rate. Again, our technique is based on the patient's BMI and weight, so we adjust that. Anybody under 30 BMI automatically gets 100 kV. So we get better imaging. For people over 30 BMI, it's always 120, and we go up to 800 MA, which is quite a bit. We use a smart prep bolus and not a timing bolus. The reason being is the heart rate changes. It can change. It changes when the patient is anxious. It will change when you get contrast every single time. So we use real-time timing bolus or smart prepping. We're also able to use less contrast doing it this way. We're not giving that 30 ml extra to get the timing bolus in. So we're able to give them all the contrast at once. Sometimes we have to re-inject these patients, and that 30 ml extra will make a difference whether we can scan them again or not. This is our protocol for our TAVR cases. We do a lot of reconstructions. We actually scan at 1.25s through the whole thing. We reconstruct our chest and abdomen and pelvis by 2.5s, and these are used for diagnostic reading. These scans are not just for the valve, they are for other things too. Our radiologist looks at every single image. We reconstruct the 5 to 95% by 10% increments for valve movement, for LVOT movement, to look at the EF of the heart, just to look at all the motions of the heart. And then we have our 0.6s at 35% and 75%. And then our 1.25 sagittal and coronal reformats. The 0.625s, 35 and 75. When we go back into the lab, we do that whole valve series. We're measuring the annulus at every single phase. We are looking for true systolic and true diastolic. 35 and 75, most of the time, that's what they are. So it just saves us time not having to go back to the scanner to reconstruct those images again. Here's our injection protocol. By using this mix, we were able to go from 125 mLs of contrast being used down to 83 mLs of contrast being used per patient. Again, if we needed to re-inject, now it's a lot safer to re-inject. We found that increasing the contrast a little bit for patients that have a BMI of over 30 actually helps in visualization. We were getting kind of like a washout technique by using the under 30 BMI, so we just decided to increase it a little bit. And it's only 17 ml difference, it's not very much. So some of the problems that we have after we're done scanning. We have an increase of heart rate during the scan. Patient had a PVC or they went into AFib during the scan. Patient breathing. Segment plus not turned on, that's on the scanner. Improper bolus timing and the IV placement. Some of those things we can fix from the scanner, at the scanner. The heart rate increasing, we're able to remove triggers on our scanner. We're able to put triggers in our scanner. We're able to delete recon windows, which gets rid of that whole segment and puts on, goes to the next one. Segment Plus, what Segment Plus does is it takes all those segments that are scanned during gating and it lines them together. So when Segment Plus is turned on, everything looks jagged. You just go back and reconstruct those in Segment Plus. Problem solved. Bolus timing and IV placement, can't really do anything about that. And patient breathing, you can't do anything about that. So this is what I was talking about, the triggers being deleted. See all the triggers on the top? Many. Causes a lot of motion in the pictures, as you can see at the picture down here on your left. When I went back and deleted some of those triggers, we got the image on the right. It's the same patient. We didn't rescan the patient. It just cleaned it up that much. Patient in AFib. Again, we can go ahead and delete triggers, and we can delete recon windows. The recon windows are where the beam actually activated at that time. It's the blue lines in the back. We can, again, delete those and move the triggers around to get a nice even scan for our reconstructions. And that's what you're looking for, a nice even scan. So the images at the top were the first EKG. They're all blurry at the top. Same patient. We just edited the EKG, and we got a much nicer, cleaner, more contoured image. So this is a breathing image. Patient breathed. You see the diaphragm moving. Not much we can do about that other than rescan the patient. This is where education comes in. This is where you really have to be very vocal in telling them, you need to hold your breath. Otherwise, we will rescan this patient. They probably got rescanned that same day, immediately. The techs have been trained to look for breathing artifacts and breathing motion, and are, to determine if the patient needs to be rescanned or not. This is what happens when Segment Plus isn't turned on. So it's all jaggedy. The difference between a poor bolus and a good bolus. With a poor bolus, obviously, it's very hard to see the walls of the area that you're looking for. You're unable to see leaflet movement. You have a poor visualization of the LVOT, and then you will have poor visualization of the iliac sizing. These, when you're starting to guess, it's not a good thing. Over on the other view, you can clearly see the walls defined. The contours are nice and sharp. Everything's sharp. there's no guessing. You know that where the end of that wall is from inside of the wall to the other side of the wall. And you know, this is the difference for the iliac measuring a good bolus versus I don't know where they're going. This is what I was talking about with your left arm and right arm injection. You have the right arm injection. The SVC goes right to SVC, runs along the side of the heart. The left arm injection goes over the arch. When that happens, we measure the carotid vessels. So when we have that subclavian going over the right carotid, it causes artifacts. Again, we can't tell where the walls are at to get an actual true measurement. When we are doing our annulus measurements, again, we're looking for true systolic and true diastolic. True systolic, the valve is open. We want to know the largest diameter, circumference, and area of that annulus. Same thing on the other end. We want to know the smallest for diastolic, so we know that range where that annulus is going to be moving in. We've had a couple patients who have EKG reversal. So when I'm measuring the annulus, or my team is measuring the annulus, we are 35 is a lot smaller than 75. What's going on? When that happens, it is really the patient. It's not something that we did wrong. But when we have to really think about when we're doing our analyzing, what phase we're doing our measurements in. It's not a routine thing anymore. It's not we do the 5 over here and then the other one's over here. We actually have to reverse that. So you need to make sure that when you are measuring, you know exactly how to label them. Because the cardiologist or the radiologist they're going to see diastolic if you write diastolic, and it's really systolic. So it will cause some issues. This is a perfect EKG. What you're looking for is nice, evenly spaced P wave before the R wave. Perfect scan. Everything comes out nice and clean. These are our 3-chamber and our valve images. What we are looking at here is on our 3-chamber, we look at LVOT motion. We look at the mitral valve even to see if there is any going to be any obstruction. Our aortic measurement, our aortic cines, they show us how the valve is moving. They show us, is it a tricuspid, is it a bicuspid valve? When we do our post-processing, we use what's called double oblique technique. We're obliquing to the cusps on our sagittal and coronal images. So it's not just a straight cut. When you do double obliquing, you are getting a true cross-sectional view of the structure that you are trying to look at. We look for the max and min diameter, we look at the circumference, and we look at the area. We also here give them a C-arm angle to kind of know where the valve is so they can put their catheter in the right cusp and at the annulus level. Some of our TAVR measurements that we have, that we give them annulus always, systolic and diastolic. LVOT always, systolic and diastolic. Coronary heights always, systolic and diastolic. These 3 will kind of determine what kind of valve, where to place it, what level to place it at, making sure we're not obstructing any coronary arteries. We give them an STJ measurement, sinus measurement, the cusp measurement, everything that they could possibly need and know before they actually go in with the patient. They don't see these images. Everything is blind to them until they inject contrast. They don't see like they can see on a CT prior to. So them having everything that they need to know before the patient comes into their room, we try to give them. Same thing with the iliac access. This is the preferred access to go. They go through the femoral arteries. We need to make sure that the route is clear all the way up for them. So we do both right and left. We do aorta. We give them the minimum diameter to make sure that their catheter will fit not hit anything going all the way up. The minimum diameter for that is, for us, is 6.5 millimeters. We have a Transcaval access if that is any smaller. And what that route is they go through the femoral vein, up the IVC, poke over to the aorta, and then continue their route there. What we have to know in the lab is what route for them to take. Where are they going to do that crossover at? So looking at that, we need to make sure that there's no calcium in the way. There's no aneurysms in the aorta at that level, and that there's no bowel or any other anatomy structure that is in the way for them. We also need to make sure that it's not too close to the renal veins or too close to the renal arteries. This is a post-transcaval image. So what they do is when they cross over to the aorta, they put an occluder in. We do post-transcaval scans afterwards. We do them 1 month, 6 months, and up to a year. The one over here on the left is a beautiful post-transcaval study. The one over on the right has a little bit of problems. There's a little bit of leaking around it. The other access that we provide is a carotid access, and this is what I was talking about, the patient being put on the table with their head to the left, because they would go in through the right side, and we are measuring the common carotid, the brachiocephalic ostium, the left ostium, and the 3 centimeters from that. We like to give them a view of the anatomy so they know how the carotid arteries are laying on the arch. When the patient is brought into the room and the technologist is ready to scan, there are things that I've asked them to really not pay attention to. One thing is you should not have any distractions when scanning these patients. Most of the time that you spend is actually talking to the patient, educating the patient, reassuring the patient, being confident to keep them calm. Once you get in the back and start to scan, it's just a few minutes. So there should be no distractions at all from outside of the scanning. Always make sure that you have enough saline and contrast in your injector before you're ready to start injecting, so you don't have to go out there. Again, time is of the essence. Patients, you walking out there back and forth, doing something and not talking to them, they think something's wrong, so they're going to get anxious. Knowing the heart rate in the heart rate rhythm, again, to set up your scan, and knowing what the GFR is in case that you have to re-inject again. These patients only have limited time. It's a one-chance appointment. We don't like to send our patients away and have to come back for a rescan, because a lot of times it takes too long. These patients know this, and that's why we get a lot of cooperation from them. We make sure that our techs are competent and confident in the studies that they're doing, and we do keep a log of inadequate studies just to make sure that if somebody is having issues, that we go back and we retrain them, talk to them, and see if they have any questions. We do about 20 to 25 heart structure cases a week. That's a lot. It's a lot for the techs, and it's a lot for our lab. Each one of these TAVR procedures for us in the lab takes about 2 hours to process. It's time consuming, and we have to be very precise. We don't just then send them out to get read. We actually get them checked. Cardiologist comes in, so they check our work. We need anything changed, we changed it. We change it right then and there. So that way it's not just us looking at it. We have them who is doing the studies looking at it. So this is some of the cool stuff that we do in the lab. This is actually mitral planning, and we fill in the lungs, we fill in the heart, we fill in the carotid arteries, the LAD, put in the chest wall, and we play it, watching the heartbeat. This is a post-mitral study, and we see the valve in there. And I take this to see, to look at the amount of LVOT that is left after the valve is placed. We have our aortic leaf movement. This is looking right into the aortic valve. So a couple other things that we do mitral planning. They do a transapical access for this, so they're going outside the patient's chest wall. So we give them all kinds of measurements, how far it is to get to the valve, how far it is to get to the left ventricle, how far away they are from the LAD, where they can align from the sternum to that access site, how much of the atrium is left so they know if they go through a little bit that they won't poke through. And then, of course, we measure the mitral valve itself. We do Watchman procedures, left appendage. And for this study, too, we also do what we call non-reportables, and we're measuring the area at the left appendage for the largest area, so we're putting in the correct size Watchman device. And this is my crew. Thank you so much.